All right, so I'm going to run through this quickly. I have 8 minutes, and we're going to look at 6 innovations from the last couple of years in arterial access. Predominantly, this will be radial-based, which I think is where much of the data has been. So first of all, radial artery occlusion. It continues to be a problem, and the goal is, of course, not occlusion. The goal is no occlusion. Give me something for this, thank you. All right, so recent developments in the radial space aiming toward no occlusions. There's been a paper, a randomized trial looking at subcutaneous nitrate, which has worked. In a blinded manner, this was tested. It reduces radial artery occlusion. Patent hemostasis, we've all been practicing for years, but some data suggesting that you should not keep your compression times too short, because if you get a bleed, then what do you do when you get a bleed? You go ahead and press super hard on the bleeding radial artery and you get occlusion. So avoid super short compression times. The most interesting thing in this space, I think, is the mechanical intervention, that is ulnar artery compression. So if you compress the ulnar artery while you have got a radial band in place, you divert all the blood down the radial artery. So that milieu should reduce the propensity for the radial to occlude. And this was tested by Sam Pancholi, the guru of radial artery occlusion interventions, in a randomized manner, the Prophet 2 trial, 3,000 patients. And just look at this with me. So on the y-axis is radial occlusion as indexed by ultrasound, and in blue is what we typically do right now, just patent hemostasis of the radial. Interesting to note that there's a high occlusion rate immediately, but much of those occlusions are recanalized by the next day. But in pink, that's the impact of ulnar artery compression, so a massive reduction in radial artery occlusion. The downside to this is right now, it's quite finicky to do this. This is Sam Pancholi's videos. So you'll see, first of all, that that radial sheath is a little higher up the wrist than you might normally do, and the reason is you're going to need 2 bands, one distally on the radial artery, on the ulnar artery, and there's a rolled-up gauze with a needle sheath inside it, firm, being pressed on the radial artery, and then the sheath is removed and a standard band is put in place. One extra point here, note how he opens the side arm and bleeds back as the sheath is pulled out. I'd encourage everyone to do this. It seems it may remove a column of blood from that radial artery. So that's ulnar artery compression. It's finicky. There is going to be innovation in this space. There will be a band that will do both of these compressions for us. So we look forward to seeing more about that. Number 2. Simple ACS, 6 French radial and a small female. I mentioned that because the radial artery was small. So a bifurcation lesion, a very straightforward one, really looks ideal for 2 stents. I think you'd agree with me there, 2 big-sized branches. Now, ideal for 2 stents, but that's not simple with a 6 French guiding catheter. You can do it, but you're probably going to need to start by doing 1 stent at a time, or a stent balloon, then a stent strategy. So the idea will be able to pop 2 stents in together. So we need large bore radial access. There are multiple methods of doing this, and I'm going to give you my bias. I think this is the best method. The sheathless guiding catheter is commercially available, hydrophilic coated guide with a beautifully smooth taper there that tapers over an 035 wire. And this is just a video of an exchanging out of a standard 6 French sheath. So you pull out the sheath over an 035 wire, and then you insert the sheathless guide, which has these same outer diameters with the same degree of stretch into the radial artery, but it's a 7.5 guide, smooth and simple. This is shaped in a standard guide manner. And you can quickly do a V-stent here, and you're done before you know it. So I think large bore radial access really can be done easily and simply, and there's no need to switch to femoral access or compromise by doing a suboptimal or a longer 6 French approach. Number 3. This was an MD female who wanted to be awake throughout the whole procedure, had no sedation, and you'll see here there is severe radial artery spasm there, and we knew that because the sheath was entrapped. It wouldn't come out. Standard treatment for this, as you all know, is to start with conservative measures, quiet voice, sedation, warm compresses, etc. Overdose the patient on all the drugs that you can think of. And then we would typically, if we had to, go all the way to propofol or general anesthesia, which will work, or an auxiliary nerve block. I encourage you to try this as a non-invasive strategy because it does work. Inflate the blood pressure cuff in the usual space, in the usual place in the arm for 5 minutes at 200 millimeters systolic, and release it, and you get flow-mediated dilation. in the radial space. I'd encourage you to do this much earlier in your algorithm. Here's this particular case. Sure, it's not perfect on the right, but it was just enough to free up that sheath and pull it out without having to upgrade to propofol or general anesthesia. Number 4, we've known for years from randomized studies that the left radial is quicker to get to the coronaries, fewer catheter exchanges, shorter fluoro times, and that's driven by a lower rate of tortuosity in the left subclavian compared to the innominate on the right. But we don't do it. And the reason we don't do it is because it's awkward for you and it's awkward for the patient. Well, Dr. Kiemeneij, who's a pioneer of radial access, has really been promoting the distal left radial approach. And the principal reason for this is patient comfort. So if you think about pulling your left arm across the body, particularly in an obese patient, it is a lot easier to keep your arm, as I'm doing right now, with the distal radial exposed, rather than having to supinate it all the way. And it is, if you try and hold your arm across here for a period of time, it is quite hard. This is much easier. So the snuff box approach or distal radial approach is really gaining traction here. So patient comfort, operator comfort. There are other theoretical benefits that don't yet have the data. Perhaps preserving the main radial artery is a good thing because you can use that for access. Maybe even a surgical conduit if you haven't penetrated it with a sheath, or certainly an arterial line. What we don't know with good numbers is the occlusion rate of this distal access and the potential theoretically for scaphoid ischemia. Right? This is the only blood supply to the scaphoid, and maybe there might be a late risk of having scaphoid ischemia. That remains to be seen. This is a great case report just published in Circ Interventions where they use the distal access to recanalize an occluded left radial artery. So here they went in, they accessed the distal, which is collateralized from the ulnar. They penetrated through the occlusion with a dilator and then a sheath, and then you'll see on the right there how the left radial is now open. A nice little strategy here. This is just to store fluoro. And the point of showing you this is there is an angle as the distal left radial is anastomosed the main left radial, and that can be a little awkward to negotiate. So you have to move your needle in various planes, manipulate your wire, and you should be able to go through. Another potential downside is with the arm pulled across the body, you introduce extra tortuosity in the radial, and here you'll see radial tortuosity and narrowing at the brachial junction, and we used a balloon-assisted guide to navigate that and do the intervention that way. One tip for access that Dr. Kiemeneij has suggested is have the patient put their thumb in this position and then put on a glove and fold back the glove over those fingers so that anchors it in place. And this, by report, does really improve the visibility on ultrasound of the distal radial artery and access. Hemostasis, there are various ways you can do it. We have found a regular band to work well in most cases. Manual pressure or other bands are also workable. Number 5, peripherals. This is a case from about 7 or 8 years ago of a femoral complication. You'll see here a retroperitoneal bleed with the bladder squished. You'll see a lacerated and destroyed deep circumflex iliac artery. That's where the sheath had been, and the patient was quite unwell. The problem here, you'll see those stents going all the way up to the aortic bifurcation, and it was not possible to cross over from the other side because of those stents. Fortunately, this was a 5'1" female with a bounding radial pulse, so we were able to get down to this region with a long 7 French sheath and deploy a Viaband stent with success. But this was only possible because of the bounding pulse and the short height. The stents and the balloons that we've had for so many years have not been long enough to do any peripheral work. Until now, and we've been asking for this for years, but finally this has arrived. We have 6 French sheaths that are super long, balloons that can reach the SFA, stents that can reach the SFA, and the SFA and the iliacs are now readily treatable via radial access. I predict this is going to be a big win for us in the interventional world. Finally, no devices, no studies, no trials, education. Roxana, Duane here is a big Twitter user. Radial first is the hashtag. For those of you that are not on Twitter, I encourage you to do this. I want to give credit to the 3 people arrowed there, Chadi El-Rais, Sheila Sani, and Sunil Rao, who really were the pioneers of putting this together. And in the last 16 months, there have been 75 million impressions with the radial first hashtag, 20,000 images or videos. That beats everything else, right? Beats everything else. This is an incredible tool, educational tool. So there's my 8 minutes. There's the 6 innovations. The final one, of course, education. I'll stress again, it's a public forum. Anybody can have an opinion, even people who don't really agree with the radial approach. All right. Thank you.
Wow. What a fantastic talk. Thank you, Dr. Gulati. It was really, really excellent. And there's no question that radial is the way to go. And I think what you gave us, these 6 innovations, are excellent tips. I encourage everyone to kind of, I'm hoping that Manos and the group here will have these slides available to everyone, because I think you just gave us so many tricks. Radial first is the way to go. Duane, Arnold, is there any way that you can imagine anything else other than radial? Is radial first in your mind always?
Oh, yeah, definitely radial first whenever you can. And even then, it's ulnar second for me, and then femoral. So I think we have a lot of options, and you should try to avoid the femoral where possible.
I think the other hashtag, which should be coincident with hashtag radial first, is hashtag safe femoral. We do have to know how to get femoral access for certain types of procedures and things that we do. And I think the extreme attention to vascular access and safety that radial operators have is translatable. And I just want to second what Rajiv said about Twitter. I have literally learned things that morning from my colleagues and done them later that day because of this method of exchanging information. And it makes a difference.
Well, no, there's no question that I think we need to kind of innovate in the femoral space, right? I mean, I think we will need it. There are still large bore devices. We have to know that technique and enhance our abilities to continue to work in that direction.
You do have to be in it to win it when it comes to radial. You have to be willing to suffer for an extra 5 minutes because you believe. You can't just pack it in and say, yeah, the nominant's a little tortuous, time to go to femoral. You have to be committed to this.
So it might be interesting, how many of you are using radial for more than 50% of your cases in your lab? More than 80% of the cases in the lab. It's pretty good.
Maybe a third, and maybe
That's
a fifth.
pretty. That's really, really interesting. So, we could say that at Mount Sinai we're behind because we're at about 35%. But I think this is important. Manos.
Well, actually, this is a great talk. I always enjoy this phenomenal talk. But the defense of femoral, because sometimes it can go the other extreme. I've seen people spend an hour trying to go through the radial loop or go to the subclavian. And there should be some common sense. Radial is first, I think I agree, especially in STEMI, ACS, but there are many cases it's not worth spending 40 minutes radiation, contrast, and complication risk instead of going femoral. And to do that, you're absolutely right. You have to know how to get access with ultrasound, micropuncture needle, and do it the best way.
And maybe we need to get more innovative in the femoral side as they have been on the radial side. I think it's always been the same thing, and I think we could go with a smaller sheaths, ability to do better holds, etc. And I think we just haven't thought about that. You make a really, really good point, Manos. No question.
I want to start a new hashtag, the rational radialist, but we'll see.